Introduction to Nursing Concepts, Part 7. This is the second part of this. As we look at blood administration, we know we have to have a physician's order. We educate the patient and get the consent signed. If they've had blood before, they may not have as many questions. The type of IV, how the transfusion will take place, how long it takes, the reactions to look for are things that we need to educate the patient about. We need to check that with the institution, they usually have policies that the RN has to stay with the patient for the first 15 or 20 minutes when the reaction is most likely to occur. But again, you have to go off of the policy of the facility where you're administering the blood. When you begin the transfusion, the doctor writes the order, we educate the patient, sign the consent, we get the initial vitals, especially a temperature, because if it's elevated, you would want to call the physician before starting the blood. Make sure the patient has a correct IV that's 18 or 20 before the transfusion. And then if you have no problems with the IV site, you would get your Y tubing, you would prime it with your normal saline, have that running before you run to the blood bank, so when you come back from the blood bank, you would have the blood and have it ready to go on the tubing where the normal saline going through the Y tubing is already being administered. Another RN goes into the room then when you have the blood to identify the patient, to read the numbers and verify that you indeed do have the correct patient, the correct type of blood, the right amount. All of that is double checked then. That slip of paper that comes with the blood then has all the numbers that they need, and if they do not match up, then you would have to go back to the lab and figure out why. Once the IV then is started per protocol, the vitals are usually obtained every 5 minutes. At the end of about 15-20 minutes, then they may drop down to every 20 minutes. As we look at our nursing responsibilities with blood administration, staying with the patient to identify any issues with a reaction and knowing to shut the blood off immediately, run the normal saline if they do have a reaction to the transfusion. That blood then would be sent back to the lab where it can be analyzed as to why they had a reaction if they did indeed type and cross correctly. Do not use any abbreviations when you sign the consent with the patient, and then document how the patient tolerated it, if they got the whole unit of blood, and post-op or post-blood transfusion vitals at 1 hour. Always go on that blood to show that they did not have any fever or other types of reaction. If they do have a reaction, page 912 and 913 in Potter and Perry talk about what you would do. Stop the infusion. Again, run that normal saline, notify the doctor, get a set of vitals. The blood bank needs to be notified. Follow the institution policy as to what you do. Typically, we collect a UA and have some blood work drawn to look for any types of problems that cause the reaction, and then make sure you document thoroughly. There is a special transfusion reaction form that is filled out, and you ask your supervisor if then an incident report also has to be filled out. When we look at the blood salvage systems, they are the person that goes to surgery for a total hip or total knee, come back, and the Stryker or Constivac reinfusion systems then give them their own blood back. With the Stryker, it's their own blood. There's very little chance of reaction. We run the blood in very quickly because of that low risk for reaction, and it's only done after surgery. If a person gets a blood transfusion, remember, we monitor for the reaction, we run it over slowly, and it's given after surgery for a low hemoglobin. So ideally, they use their own blood. This Constivac is kind of a pain in the neck. It's from the moment that they hit the recovery room. 6 hours later, then you have to have this blood retransfused from the Constivac. It is then disconnected, thrown away, and the patient at that point then just has like a regular hemovac attached to their wound site so that they are able to remove the drainage from that. Alternative sites for infusion then, arterial is used for diagnostics. We get ABGs or arterial blood gases from the arterial site. They're usually either done by a physician or a respiratory therapist or lab people, depending on their level of training. They can be used sometimes in high-risk patients with severe respiratory issues. Intraperitoneal infusion is usually your peritoneal dialysis. Some of the chemotherapy is given into the peritoneum, but your risk for an infection in that peritoneal cavity is one of the concerns we have, as well as shifting of the fluids and causing some respiratory distress or ascites with that. Subcutaneous is usually your insulin therapy. Perhaps an insulin pump that a diabetic wears on their abdomen would be a subcutaneous continuous infusion that they would have. Intraspinal is usually for pain control. It's often called an intrathecal after surgery or with a cesarean section. And then intraosseous is into the bone. We access the vasculature of the bone and provide a way for emergent rapid delivery of medications or blood or IV fluids. It's a short term. It's done just to get us out of the woods, get this patient to a place where they can put in a central line or something more long term. Our risk for intraosseous again is osteomyelitis, which is very long term treatment, and we use either the distal femur or the distal or proximal tibia for that. So as we look then at these last sites, we can see then the intrathecal and the epidural. Intrathecal is done by your anesthesiologist, your nurse anesthetist, physicians. Medication administration by an RN is only done by your Nurse Practice Act. I have never given an intrathecal med. If something is needed to be given that way, the nurse anesthetist or anesthesiologist comes to the floor to do that. Local concentrations of meds needed to be delivered. They're absorbed directly into the tissue, and like I said, a lot of times for pain control. My experience has been your intrathecal is a very small tubing and it has a yellow stripe through it to help you identify this is not my peripheral or IV site, this is the intrathecal. The other thing that I would highlight for your intrathecal and epidural, if you have pain meds that have been given in that area or have a pump running with medications into that area, no other oral meds or IV meds are given. So if I have a patient that has epidural meds running or they had an epidural flush or flood that day, if they're not having pain control, I call the nurse anesthetist and say, you know, they need something, they're in pain, this is what's going on, and either then we have an order specially to give something or they come and reevaluate for us. With these medications, they can have problems with their bladder and not being able to void. The other complication I've seen with these as well is that spinal headache post procedure after it's done. Our treatment for the headache is to give caffeine, try to keep them quiet, rest, or as a last resort, they will draw blood from their vein and then use that blood to put into the space, and the cells then plug the hole where it's leaking that caused the headache. As we look at our nursing diagnosis related to IV therapy, there are many. I think of fluid volume overload. I think of risk for infection. Your patient that's older, confused, maybe a little bit weak, might be at risk for falls because they have the IV pole. Risk for IV trauma is talked about in your nursing diagnosis handbook. So there are many that relate to IV therapy, but as we wrap up this unit and start thinking about the different ways that we can give medications, we just have to be respectful of the fact for risk for infection, fluid overload, and how the patient is tolerating that. Our blood, I can expect a lot of questions on NCLEX related to blood administration because a lot of that is nursing judgment and nursing assessment that goes in with that. And we have part 8 and we will be done with IV therapy.